Hi, I'm Dr. Ryan Kazemi. First, I'd like to thank Dental XP for the invitation to speak to you for today's webinar. I come to you from Bethesda, Maryland, just outside of Washington, D.C. area, and from our educational and training center, the Facial Art Dental Forum. Today, I would like to spend some time talking about the challenges in implant dentistry, more specifically the rise in Peri implantitis and what we can do about it. Let's talk about a patient, an example. It's a 27-year-old female who came. She had an implant placement done on number 12 about a year ago, which was first restored after about 3 months, and then she reported some symptoms of pain for months following the restoration. The history of treatment is that she underwent a series of antibiotic sessions, 6 different sessions, and she also had periostat treatment done, as well as deep cleaning several times in an attempt to control her symptoms, and ultimately the restoration was removed by her dentist. And this is how she presented in September of 2015 while the antibiotics were being given and the deep cleaning. Subsequently, in March of 2016, she presented with some increased bone loss. And finally, around June of 2016, when she presented to me, yet with additional amount of bone loss. And at that point, the restoration had been removed and just a healing abutment was placed. So during this entire phase, she went through 6 sessions of antibiotic therapy, intracellular antibiotics, and also several sessions of deep cleaning, which none of them responded or was effective in her therapy. We'll talk about this case a little bit later, but first I want to kind of touch bases on the implant complications, which can happen in various facets of implant dentistry. It can certainly affect the implant body itself. It can involve complications in abutment and restoration. It can come from the bone grafting complications, and also from aesthetic and functional aspects. But today I want to spend a little bit more time on the peri-implant tissue complications, which includes peri-implantitis, as well as recession or loss of attachment. I think what we can kind of realize, and has been reported by many, is that complications seem to be on the rise overall. In fact, we have a specific site on our website that focuses on implant complications, providing patients solutions and understanding of the various issues that we're observing. So first, I think it's important to understand the impact of an implant failure. From a patient standpoint who has already lost some time and often presents with less bone, less money, and less confidence, we can also really understand the impact of the implant failure from a time and an economic standpoint for the treating doctors. If you kind of look at the entire treatment for a redo of a case of implant failure, everything from follow-ups to implant removal to the planning and replacement of the implant and refabrication of the restorations, we can see that there is a vast amount of time and economics that are involved both for the restorative dentist and the surgeon. And in essence, the amount of time that's spent is somewhere around 5.5 to 7 hours for the restorative dentist, with additional cost to them of somewhere around $2,000 to $3,000, and for the surgeon another 6 to 9 hours for additional cost of $3,000 to $3,700, and this is really based on the approximate hourly cost for the time spent for these treatments. Of course, additionally, the impact of the implant failure has to do with the patient's experience and sharing that experience with others, as well as on social media. And these negative experiences can certainly result in poor reviews for the treating dentist, and also really change the public outlook on implants and decreasing perhaps their confidence on what implants can provide. This ultimately can result in decreasing patients' confidence and treatment acceptance, which will negatively impact the dentistry and our practices. So I think we need to kind of really think about the long tail of an implant failure and understand that it is rather significant. We also need to think about really doing responsible dentistry. We need to depend on our dental implant companies to provide us with the components, the quality implants, and the good research, so that as clinicians we can make good decisions on what type of implant to use and how to rehabilitate these patients. We also need to use evidence-based dentistry. We need to take our experience, the scientific evidence, and also the needs of the patients to be able to come up with the treatment rationale and treatment protocol that is based on evidence. We need to have individual expertise. Experience and expertise of the treating doctors is immensely important in delivering the type of dentistry and implant dentistry that we want, as well as the team approach involving the thought process and the efforts of a surgeon, restorative dentist, and the laboratory to provide predictable treatments. So let's talk about peri-implantitis. Let's review what it is, its etiology, classification, and some management and prevention strategies. So peri-implantitis is really defined as an inflammatory condition caused by plaque retention on or around the dental implant. And it essentially goes through 4 stages. Peri-implant mucositis, which if untreated, it'll can lead to peri-implantitis, which again, if untreated, can progress to infection and ultimately total loss of attachment around the implant. Peri-implant mucositis is really an early form of inflammation. Typically, patients exhibit mild discomfort, redness, mild swelling, and perhaps mild bleeding on probing. And of course, it can progress to peri-implantitis if it's not addressed early on. Peri-implantitis is characterized by an increasing pain, redness, swelling, and bleeding around the gingival tissue. We'll talk about the classification that I proposed, 4 types of it to be specific. And generally, this stage responds relatively poor to most treatments, particularly when it is in more advanced form of it. The next stage is where an infection can occur. This is an unresolved peri-implantitis, which can transform into a full infection. There is increase in pain, swelling, significant loss of bone and attachment. Generally, we might notice purulence, and of course, possible implant mobility at this point. And of course, when it progresses to its end stage, there's further progression and destruction of the supporting bone with total loss of attachment, and the implant will essentially become mobile with pain on the site, and not too often, the implant may actually become completely exfoliated. So the question is, why is peri-implantitis is on a rise? And in my experience, there are 3 main reasons why we're noticing an escalation in peri-implantitis currently. The first reason is placement of implants in the pre-digital workflow, or perhaps even placed currently without digital workflow. So here's a patient who presented with 3 implants that were placed. That again, patient presented with pain and site inflammation and bone loss evident on the x-rays. And we can see that the implants were placed inadvertently or quite pallidly out of the envelope of the supporting bone structure. There is loss of bone, the crestally peri-implant loss of attachment, and the implants themselves are quite evident on the CT scan as being malpositioned in various directions. In fact, we can kind of see that during the removal of the implants, we can see the trajectory of the implants and how they're positioned. So this patient was treated without any cone beam CT scan, as well as no 3D planning. And hence, it often not unusual to have poorly positioned implants, which can lead to complications as such. I think the second reason that we also see in peri-implantitis is implants that are placed correctly in position, however, they have inadequate tissue, whether it's inadequate bone or inadequate soft tissue. And we can kind of look at this patient that had an implant placed, and for a long period of time after the implant placement, she had been complaining of discomfort and pain on the buccal aspect of the implant. While there was no evidence of swelling or purulence, she continued to be symptomatic, and the cone beam CT scan demonstrated clearly that there is lack of bone and quite thin soft tissue on the buccal aspect of the implant. Obviously, this implant is positioned not correctly with inadequate tissue. And ultimately, during the exploration of the site, we can appreciate the lack of bone covering the implant. Because the patient was symptomatic for a long time, while the an alternative treatment could be graft and try to establish some sort of a coverage, she elected to have the implant removed and retreated at the later time. So here's the implant removed, and the site is grafted, and then following routine guided bone regeneration process and PRGF, and then closed, and then come back in 4 to 6 months later for replacement of the implant. So the third reason that peri-implantitis may be on a rise is the placement of implants by inexperienced clinicians. Here's a patient that had an implant placed by a clinician who had only placed a few implants and followed more of a conventional analog dentistry. There was no CBCT or 3D planning done. And the implant was placed slightly close to the lateral incisor. Patients started to exhibit localized pain and discomfort for some time after the placement of the implant. Eventually, when the implant was exposed, there was clear loss of attachment in the mesial aspect with a probing depth of 10 millimeter plus in the region. So the question is, why did this occur? Again, we look at the CT scan, we can appreciate the fact that the implant again is positioned outside of the envelope of the bony foundation with no buccal bone present, and also placed close to the root. And of course, the protocol that was followed for placement of the implant may have been compromised, ultimately resulting in the loss of attachment and a poor outcome. And I think the question that often is asked is, does experience matter? The critical importance of proper planning, diagnostics, and experience of a clinician in both the surgical and restorative aspects. There was a study that was done by Da Silva, which looked at the outcomes of implants and restoration placed in the general dental practices. It was a retrospective study where they looked at 922 implants from 87 practices for up to about 4 years. And they had about 18.7% of the implants were classified as failures, which is way above what we normally accept as our success rates. And there was various reasons that were reported: history of periodontitis, sites with pre-existing inflammation, type 4 bone loss, and also there are some cases of immediate implant placement. And ultimately, the results of the study suggested that the implant survival and the success rate in the general dental practices may be lower than those reported in studies conducted in academic or specialty settings. I think there's no question that the experience of the clinicians, both from the restorative and the surgical aspect, do matter in the outcomes and the predictability of our cases. And I think that the intensive training and continuing education for general practitioners who are increasingly placing dental implants and restoring them is really a crucial factor, and this is something that we need to work together to continue to support. When we looked at our all the various complications involving peri-implantitis, it appeared that in over 90% of cases, peri-implantitis was caused by poor diagnosis, poor planning, improper treatments, and improper implant position. And we discovered that there were basically three categories of such etiologies. One was dentist-induced, the second was patient-related, and the third category, to a smaller percentage, was idiopathic, no known cause for it. The dentist-induced etiology for peri-implantitis, again, was mostly related to planning, diagnostics, inadequate tissue, and inadequate or poor execution, as we discussed earlier. Patient-related categories, which really involved about a smaller percentage overall, included, poor oral hygiene, inadequate care, certainly smoking and periodontal disease, or existing periodontal disease, and some health issues were noted to be the most likely reason for the complication or the peri-implantitis. And there was an idiopathic category where there was loss of attachment with no known cause, perhaps due to physiology, perhaps due to contamination of the implant, maybe pressure necrosis, or perhaps poor implant quality, but couldn't really find out exactly the reason behind it. Looking at the etiology, study by Smith looked at the risk factors for development of peri-implantitis, and he listed a number of factors that seem to be common, and this has been noted in various literature. Smoking, history of periodontitis, lack of oral hygiene and compliance, systemic diseases, iatrogenic causes, certainly soft tissue defects or poor quality of the tissue at the area of the implant itself, and also history of one or more failures. And I think what's interesting is that the smoking and history of periodontitis seem to be the most prevalent reasons for the development of peri-implantitis, and this was also reported by Wallow, looking at the influence of smoking and periodontal disease, that it can increase its risk by up to 4 to 4.7 fold. Incidentally, when we look at all these risk factors, majority of them, except the smoking, seem to be related to the diagnostics and treatment planning, which perhaps can be prevented and avoided in majority of cases. And I think this kind of supports the observations that we had with 90% of the peri-implantitis cases, again, being related to diagnostics and planning aspect of the treatment. So when we look at the prevention of peri-implant disease, it really starts with a sufficient and structured planning, including individual evaluation, minimization of the risk factors, including smoking, compliance, oral hygiene, periodontal disease, systemic disease, and also establishment of optimal soft and hard tissue conditions, and also a choice of correct implant design, and followed by maximally atraumatic approach and regular clinical examinations with periodontal probing status. So these are all the important factors in prevention of peri-implantitis. When we look at the patient-induced factors for peri-implantitis, poor oral hygiene has always been cited as one of the potential causes. I think it's important that we provide and create a customized and an easy home care regimen and protocol for the patients with emphasis of their role in protecting their investment, and also really demonstrate how it works. So the importance of home maintenance could not be underestimated. We provide patients with lots of tools to be able to take care of the implants post-treatment. We have videos that we've created with our hygienist colleagues, which is available on our site for access. And this is really a way to provide patients with an understanding of what they can do to maintain the plaque of the implant for long-term success. Inadequate regular care certainly is an issue. We generally recommend a customized regular care for patients every 2 to 4 months, depending on their individual needs, of course. This requires a written plan provided to the patients and have them sign it so they kind of understand what the recommendations are from the get-go. And lots of emphasis on the importance of compliance, not only to protect their investment, but also to keep them within your support or a type of warranty that is maybe provided for any kind of treatments. Of course, in the event of complications, the patient has not maintained the compliance, they should be at least informed that they're responsible for any additional visits and additional work. So I think that this is an important part of the conversation with the patient to keep them on the right track. Smoking, of course, is a large risk factor. It's been reported by several studies. This one study basically indicating that 78% of the implants in smokers had some diagnosis of peri-implantitis, while for non-smokers it was noted about 64%. And also another study by Rink reported that smokers had odd ratio of 3.8 of developing peri-implantitis or mucositis, and about 31.6% of developing peri-implantitis. So there's clearly evidence and observations in the risk of smoking developing problems. I think it's important that we discuss the risks with or associated with the smoking with the patients and inform them of the potential poor healing, infection, integration issues, and bone loss, and of course peri-implantitis that ultimately can result in failure. I think patients need to understand and take an active role in it. We need to educate and help them quit on their own terms. I think it's important to realize that implants is not necessarily an absolute contraindication in smokers, but it needs to be done cautiously and also with a lot of education with them. I think it's important to have a written informed consent to patients who smoke, to really advise them of all the potential complications that can occur so that they're informed upfront about their role in a successful outcome. And also, if possible, and this would be preferable, to have some sort of a program where they can begin early to perhaps quit smoking prior to the treatment, and there are various types of strategies or treatments that are available that can be offered to patients. Smokefree.gov can provide some information for patients on how they can basically stop smoking prior to the treatments. The next patient-induced etiology for peri-implantitis is existing periodontal disease. Again, the smoking and periodontal disease are the two major factors. And I think similarly it's important to discuss the risk with patients, initiate periodontal therapy, and control the existing disease as much as possible. Certainly, in my experience, it is a relative contraindication to place immediate implants. I'd rather extract the teeth, graft it if possible, and then place the implant secondarily into a site that has been treated and void of any plaque and bacteria. really close monitoring of these patients, and be very cautious about implant placement adjacent to teeth with existing periodontal disease. It's important to control the disease first, eliminate the toxins first, and then place implants next to teeth with existing disease. Of course, the health of the patient is also an important factor. Those with uncontrolled diabetes, radiation to head and neck area, bisphosphonate therapy, patients with immunosuppression, as well as xerostomia, can have increased risk of peri-implantitis. When we look at the larger category of etiology for peri-implantitis, as we mentioned, about 90% seem to be related to treatment planning and dentist-induced. And these are some of the examples. The majority of these complications are really due to inadequate planning, inadequate diagnosis, inadequate tissue, whether soft tissue or bone, and also just poor execution of the treatment. And here are some of the types of situations that we see quite often. First is placement of an implant in insufficient bone and choice of the wrong implant diameter, which often results in buccal dehiscence and lack of tissue coverage, and hence exposing the threads and potential issues there. Poor implant alignment is a really frequent observation, such as this patient's, where the implants are placed entirely way too buccally with loss of tissue and loss of bone. This again exposes the threads to the oral environment with increased susceptibility to inflammation. Apical placement of the implants, when implants are placed too apically, because that's where the available bone is, this can ultimately create a very difficult access for plaque control. Patients have very difficult time cleaning and maintaining the area, and certainly this can start to begin a process, as we can see in this patient, where the crestal bone should be and where it is ended up basically way too apical, and this would be practically impossible for a patient or even a hygienist to access for proper plaque control. Immediate placement and grafting is something that can be a risk factor. I think it's important to realize that there's a high risk when we have simultaneous bone and soft tissue grafting, placement of the implants and the membrane, specifically in thin tissue biotypes, or when there is thin or no buccal cortical bone available. I think one of the rules that I often follow, and Dr. Tarnow, our colleague, has talked about this many times in his presentations, if there is no bone, there is no implant. So I think it's important to have the adequate bone and soft tissue for immediate placement. Otherwise, it's better to stage it where we can develop the foundation and place the implant later on. The outcome of these cases can be generally poor, and we should avoid it. So hence the one miracle at a time, staging the treatment, and not try to achieve too many outcomes in a single day. Immediate implant placement in sites with existing periodontal disease or infection can certainly increase chances of infection and peri-implantitis. So we need to be super cautious about removing teeth, cleaning it out, perhaps reconstructing the bone through GBR, and come back on another day in a delayed fashion to place the implants, and not subject the implant to the bacteria and the infection in the area. Also, implants placed adjacent to teeth with active disease, whether it be an active periodontal disease, whether it be an active lesion of endodontic origin, as shown in those two x-rays on the right side. These can certainly increase the risk of infection on the implant. So I think it's important to address the periodontitis, to address the endodontic lesion, prior to placement of the implant to make sure that we are not increasing the risk there. Hence, an endodontic and periodontal diagnostics of the adjacent teeth prior to the implant placement is extremely crucial. Next category is immediate placement when there is no bone. We talked about the risk in inadequate bone and tissue with enhanced dehiscence, and of course what we discussed earlier. Poor abutment and crown fit can increase the risk of inflammation around the implants. This mainly has to do with inability to deplaque the area, which can start mucositis and progress to deeper inflammation. Thin tissue biotype is always a risk factor in any type of treatment, so we need to be super cautious about enhancing the bone, enhancing the soft tissue, and grafting techniques to be able to have the implant in adequate bone and also thick soft tissue. And of course, poor emergence of the restoration itself can induce implantitis. This has to do with really poor design of the abutment and the crown, with poor contour, again, making the site difficult to maintain clean. Residual cement, of course, is a huge problem, and it's been cited by many as to be a major contributor to peri-implantitis. And essentially, whether the cement is too deep, where the margin of the restoration is, and they're very difficult to remove, or whether there is just excessive cement and has not been removed and forced into the tissue. In both situations, peri-implantitis is highly likely. Wilson published a paper looking at the residual cement in a group of patients with peri-implant disease, and noticed that there about 81% of the sites had inflammation with the cement on the site. And the average time before the clinical signs or symptoms happened was about 3 years. So it might not see the evidence of this right away, but certainly down the line, the impact of the cement will be more observed. One of the questions is that we always ask is peri-implantitis the cause of bone loss or the result of bone deficiency? In other words, which one is first? Does the peri-implantitis lead to gum and bone tissue loss, or is it the loss of tissue that can lead to peri-implantitis? I think it's important to realize that both can occur. As in this particular patient with peri-implantitis, we can notice that it really is the lack of bone and soft tissue on the buccal aspect that ultimately led to the peri-implantitis. Whereas, in contrast to this particular case, where the peri-implantitis that developed around the implants ultimately led to loss of tissue and bone. So it can really go both ways. And I think one of the important realizations is that when it comes to retreatment, there potentially is a higher risk for patients who have had peri-implantitis with loss of tissue versus the other. So we need to kind of consider that in our treatment planning. Finally, we have a etiology of peri-implantitis, which we call idiopathic, with no known cause. So here's a patient who had the extraction of a tooth that was non-restorable due to a vertical fracture and bone loss. The tooth was initially extracted and grafted to restore. So 6 months later, patient was seen for 3D diagnostics and planning. The implant was placed using a CAD/CAM surgical guide with complete accuracy from our 3D workup. And about 4 months later, when the patient was seen, we can see that there is evidence of some loss of bone at the crestal aspect. Now, one can certainly argue that this particular implant, which has a platform switch built into it, perhaps the bone is remodeling down to the first thread, and that the bone loss may be within physiological range of remodeling. However, I think we need to really kind of ask the question: is this start of a peri-implantitis, and how are we going to address this? So I think it's important to realize that even with appropriate diagnostics, methodology, expertise of specialists, and right materials and techniques, peri-implantitis can still occur. Whether it be contamination of the implant during placement, excessive bone remodeling, maybe the individual healing physiology of the patient can be different, and also potential compression necrosis. These are all the various things that may play a role, and ultimately it's important to monitor closely and treat as necessary. When it comes to classification of peri-implantitis, Fromm had proposed this classification by describing the early, moderate, and advanced, basically really categorizing it based on the amount of bone loss, 4 millimeters for early, 6 or greater in moderate, and greater than 8 millimeters in advanced bone loss. When we started to look at the peri-implantitis cases in our practice over really the last 20 years, you started to kind of look at more factors that I felt were more descriptive of certain situations. So we really devised this new classification that really looks at a number of different signs: pain, bleeding, soft tissue recession, bone loss, whether it is purulence, the mobility, and also various changes in the color. And based on how they present a different kind of classification, going from peri-implantitis or peri-implant mucositis to peri-implantitis, which I describe as 4 different types: type 1, type 2, type 3, and type 4. And ultimately infection and non-integration. So it's a little bit more of a detailed way of looking at the classification, and each providing a certain amount of information to the clinician in terms of possible treatments. As we discussed the peri-implant mucositis, we see gingival inflammation with no bone or soft tissue loss. At this stage, the gingiva is really kind of red, inflamed, maybe painful to touch, maybe some bleeding on probing. In peri-implantitis type 1, there's increased inflammation with pain and swelling edema, but still no bone or gingival loss at this stage. The type 2, there is pain, redness, bleeding, but we start to see evidence of bone loss. However, the gingival margin is still intact. There is no loss of gingiva. There are 2 types, type 2A and type 2B, that may fit into this presentation. In type 2A, there is bone loss, but about 1 to 4 millimeters, and still no loss of gingiva. And in the type 2B, there is bone loss greater than 4 millimeters, again, with no loss of soft tissue at this stage. And here's an example of a patient with type 2A, which was treated. A patient had the implants placed and restored, and due to poor position of the abutment and the plaque retention, she started to develop some loss of crestal bone at the mesial aspect. Ultimately, the restoration was removed. The implant was uncovered. The granulation tissue was excised. The surface treated, and the detoxification and degranulation was completed. Here we can showing the GBR technique to graft with the GBR membrane, and we come back about 4 months later, and we can see the reestablishment of the attachment and ultimately refabrication of a new restoration. The next category of peri-implantitis is what I call type 3. In these patients, there is pain, redness, bleeding, of course, signs of inflammation. And now we start to see loss of bone on one side of implant. And also loss of gingiva or recession at this point. So this is in contrast to the type 2 where there is no soft tissue loss. In type 3, we have bone loss and now loss of soft tissue. And also I categorize this in 3A and 3B. In 3A, there is bone loss 1 to 4 millimeters. And if it's more than 4 millimeters, a category of 3B with loss of soft tissue. Here's a patient that fits into type 3A, placement of 3 implants that were poorly positioned. There is obvious loss of soft tissue around the implants, and of course loss of bone on the buccal aspect, mainly due to poor positioning. Ultimately, these implants, of course, cannot be restored, removed, and grafted to restore the alveolar ridge using GBR technique and PRGF, and then closed and prepared for replacement in a delayed fashion. Another patient with category type 3A with loss of bone on the buccal on one side and loss of soft tissue is this patient that had an implant placed inclined, too inclined on the buccal aspect with loss of tissue. Ultimately, the implant was had to be removed using a traumatic reverse torque technique. The implant is explanted and removed, and the soft tissue and the bone are allowed to heal and then prepared for grafting at a later stage. Really the point or the goal at this point is to reestablish the soft tissue by just secondary intention healing and come back later for retreatment. The next category of peri-implantitis is type 4, where we have severe inflammation and there is loss of bone on more than one side or all around the implant. So in type 4, we have more advanced bone loss on more than one side and potentially all around it. And there's two types that I describe here. One is the type 4A, one is the type 4B. The type 4A, we have the loss of bone, significant loss of bone, however, normal gingival level, as shown in the patient in the middle. And the type 4B is significant loss of bone with loss of gingiva as well. Here's an example of a patient who had the implants placed for a 4-unit implant-supported bridge in the anterior area, and was initially provisionalized, and about 6 months later, there is evidence of significant bone loss all the way around both implants, and with evidence of pain and discomfort and bleeding around the soft tissue. However, noting that the soft tissue level has not changed. There's really more of a pocket in the area. And the treatment at this point was to remove the implants and restore the bone. So the implants were removed, again using reverse torque technique, and the site was cleaned out, and because of the 3-dimensional defect, both height and width deficiency in the areas, using the tie mesh technique to restore the deficient bone, and allowed to heal for about 7 months, and then return, and the patient using a transitional prosthesis during the interim, and then come back in about 7 months later for restoration or replacement of the implants into the newly developed bone, and finally requiring some soft tissue vestibuloplasty techniques to restore the vestibule and attach gingiva, and ultimately restored by a type of a hybrid design prosthesis in this case. Going back to our patients that we initially talked about at the beginning, which really fit a type 4A, this is significant loss of bone and peri-implantitis, but with normal level of gingival tissue. The only treatment option is to remove the implant. In this case, the implant was slightly mobile and it was simply removed, not requiring a reverse torque technique. The site is completely cleaned out. All the granulation tissue is removed, and a flap is developed on the buccal and the palatal aspect with a significant defect. At this point, we can go ahead and prepare the area for a bone graft using a GBR technique. Here's our demineralized freeze-dry bone with PRGF packed into the area, covered with our GBR membrane, and then followed by a placement of our PRGF membrane, and then a tensionless closure over the grafted site. Another patient with a type 4B presentation, again, loss of bone and loss of soft tissue at in this category, where there is peri-implantitis, loss of bone around the implant, and now we have deficient tissue. And in these cases, the implants require removal. Cleaning the site, simultaneous sinus lift graft was performed. Bone grafting was done to restore both the sinus floor as well as the site of the implant removal. I think it's important to sometimes stage these cases if there is inadequate soft tissue for closure. However, in this case, it was possible to have a closure with the existing soft tissue. And then ultimately, after about 6-7 months of healing, the patient is seen for 3D diagnostics and planning, fabrication of our surgical guides, and now we can have adequate amount of bone and the soft tissue to be able to support the replacement of 3 implants as placed as such, and ultimately allowed to integrate for about 4 months in the grafted bone. Here we can see that we have good amount of keratinized gingiva and finally restored with implant-supported fixed restorations. Here's another patient with the type 4B, again, loss of bone and loss of soft tissue, in which there is almost a complete loss of attachment at this point, but not quite infected. So in this case, the implant again is removed. The site is degranulated and grafted to restore the deficiency as much as possible. However, there are very often, not unusual, that a secondary bone grafting may be required to restore the deficiency of the bone that was successful to some degree in the first grafting, but requires a secondary grafting. When it comes to implant infection, patients experience pain, redness, swelling, purulence, and of course, we could have bone with or without soft tissue loss in these cases. Ultimately, the infection was characterized by pain and purulence. In this case, it's extremely difficult to manage and treat these cases, and majority of times with significant loss of bone and attachment, the implants require complete removal, as was the case in this case that we showed earlier. The implants had to be removed with no bone and attachment really stable enough to hold the implants, and with continued infection. Ultimately, the patient developed a significant 3-dimensional defect, which had to be reconstructed through multiple grafting procedures consisting of interpositional bone graft, and then a secondary procedure using GBR technique and time mesh to restore the crestal bone, both in terms of width and height, and ultimately allow the bone to mature for about another 7 to 8 months, and then having adequate soft tissue and bone for replacements. Finally, we have the category of implant integration loss, where there is pain, redness, swelling, possible infection, but a significant bone loss, and at this point we see there is implant mobility. So I think when it comes to treatment considerations, of course we have the options of implant removal or grafting and trying to retreat the existing implants. And I think what it comes down to is, in our experience, the only predictable treatments for peri-implantitis, and that's type 2, 3, and 4, and also implants with infection, as well as implants that have not been integrated. Really the only predictable option is the removal of the implant, restoration of the missing tissue, and then replacement with a new implant in a delayed fashion. I think it's important to emphasize the keyword predictable. Several treatments have been suggested for grafting and also laser treatments that have been described in the literature with some degree of reported success. However, there's no long-term results or substantiated evidence-based support for these procedures and how they work in the long term. Now the question is, once peri-implantitis happens, what can we do about it? Of course, we talked about the various types of peri-implantitis and various treatment modalities. And I think that we can kind of break this up into sort of 3 different stages. First, we can look at, before peri-implantitis happens, what can we do about it? And then we can look at some strategies of while it's happening, and of course, once it's happened. So before it happens, I think the most important thing is to prevent it. I think it's important that we have a very accurate risk management process to be able to know which patients may potentially be red flags. We need to follow a total digital planning protocol. We need to build more tissue. We need to have ideal implant placements and ideal restorations. So I think, as we discussed earlier, if 90% of our complications are due to poor planning and diagnostics, we can eliminate majority of these cases by adhering to best practices before it even happens. If we notice that there is evidence of peri-implantitis or inflammation, the key is early management. Eliminate the factors that might be contributing to it. Monitor the patient really closely. And certainly abort the treatment if it's very guarded. It certainly does not help to just sit there and watch it. So we need to have some sort of an early intervention to hopefully be able to stop the process from progressing. And once the peri-implantitis has occurred, once it's happened, we need to come up with a definitive management, whether it's going to be the implant removal, whether it's to treat and regenerate attachment. I think the key thing is that, again, we cannot sit there and watch it and just go by antibiotic treatment only or laser treatment only. We need to come up with a definitive management once it's occurred. We should also talk about the option of the implant removal, which in many cases of complications, and certainly types 2, 3, 4 infection, and also this not integration categories, we need to consider implant removal. Of course, the previous techniques of using the trough fiber to remove implants is really no longer an accepted technique. It's entirely way too traumatic, and we need to sort of adopt the newer techniques, which provides for an atraumatic, a non-invasive, and a flapless technique for the removal of the implants. And the example that we showed earlier, as well as this patient, where we can use a reverse torque screws to attach it to the implant and be able to provide a reverse torque to break the integration between the implant and the bone, and essentially remove it without excising or removing any bone in the site. Of course, this procedure can happen much easier when there is already loss of bone around the implant, but there are some instances where the implant may be fractured, the bone may be quite thick and dense, especially in D1 or D2 bone, and of course this technique needs to be modified for those particular patients. But ultimately the implant can be removed quite easily and readily without a single incision, and then degranulate the site, irrigate, cleanse, perhaps allow it to heal like a normal extraction site, especially if the soft tissue is compromised, or certainly bone graft if necessary to preserve the existing bone, and then plan for replacement at a later time. Some final thoughts on peri-implantitis. I think it's important to first look at the prevention through patient communication and education, complete diagnostics, careful planning, expert execution, team approach, respect to biology, and practicing really a one miracle at a time philosophy. I think majority of our peri-implantitis cases can be prevented, as talked about earlier, by really following this structured and strict rules. The next is we have to at some point face the reality and make some hard decisions to move on. If we're dealing with an implant with it's ailing or failing and it does not seem to be responding to early intervention, certainly watching it and tiptoeing around it does not help. We need to make some hard decisions. We need to communicate with the patients of removing and redoing the case rather than subjecting them to additional time and investment and costs of retreatments that do not work and have no evidence support in the literature. So we need to give really attention to removal of a failing implant, which is really now much easier and a lot less traumatic than it used to be. This is perhaps a better service for the patient rather than the more costly and unpredictable treatments that may or may not work, and also certainly not to tiptoe around it. And finally, the retreatments are possible and often successful, but it requires time, requires patience, and a very careful and methodical approach to achieving it. I hope that I was able to provide some insight of my experiences with peri-implantitis and where we are and some of the strategies in not only diagnostics but also prevention and management. For those who are interested in understanding the dental implant bone grafting complications, we welcome you to join us for a 2-day course and symposium on September 8th and 9th here in our center in Bethesda, Maryland, both on-site and also live stream. So I welcome you to join, where we'll be discussing both the restorative, surgical complications. If any questions, of course, you can always reach me, my office number and my email on our website. I welcome any questions and your feedback. I thank you for the opportunity to speak to you today. And again, thanks for Dental XP for making this possible. Thank you very much, and wish you all a happy day.